like most of our drugs, it's broken down in the liver. So if you give lots and someone has liver function, it can cause
like
that.
I really need to be able hands off this kind of talking about it.
Okay. You're welcome.
It's one. Now we want to oh, really? Wow. Who's there? Yeah.
Well, maybe in the.
Okay.
Oh. Well, then if you have no good. Person. You remember. Then I told them, like, oh, after tricks, you come here to Woodland Hills after. And I go, it's bad, dude. I was telling you. Should say. They asked. They asked for the.
Oh. Well, it's the east. Yeah.
The drug, that's the one I have. You got to focus on the drug.
I'm like, yeah.
Question for you guys who are any of you guys doing clinical at a non-Kaiser? Okay, good. So in terms of the drugs in the OR, are they in a Pyxis or are they in just a drug cart? In a Pyxis? Where are you guys? City of Hope. Okay, Santa Monica.
Yeah.
It is 11:30. Thank you, sir. All right, so here's the plan. My big mouth speaks for a maximum of an hour on this. We do 30 minutes of vitals to reinforce the information of MA and the drugs, and then we go home. Sound good? Good. All right, so totally switching from MH to pharmacology. So this was a pharmacology lecture of drugs that are not your typical anesthesia drugs. So it's not propofol, it's not a narcotic, but there are other drugs that we give to manage most often hemodynamics. I'm going to talk a little bit about antibiotics and so forth. Okay. You guys got that? All right, good. So here's the focus. Just like we did last time, we're going to focus on pharmacodynamics, meaning how does the drug affect the body? Does the drug make the blood pressure go up? Does the drug make the blood pressure go down? Does the drug make the heart rate go up or the heart rate go down? Okay, are we good? Pharmacodynamics. The second thing is the mechanism of action. How does the drug work? And the third thing is, what do you need to know about the drug? So for instance, if someone had MH, you certainly can't give them SIBO, correct? Good. Okay. I want to go over some terms because you may not know these terms or you may know them very well, but I don't want to make an assumption. So when we talk about cardiac contractility, the heart's a muscle, right? It's cardiac muscle. So when we talk about contractility, we talk about the degree of squeeze. And the degree of squeeze, another name for it, the physiologist term, is the inotropic state of the heart, and it's written there for you, the inotropic state. The harder the heart squeezes, what do you think is more, is increased? It's got blood in it, right? Good, I like it. What comes out of the heart, so cardiac output. Good. Vasodilation, what does that mean? Vasodilation. Say it again, good, I want to hear you. The vessels are expanding. Vasodilate, so to take vessels here and make them dilate. Now look at this, look at my silly hand. Maybe this will help. Why would you give a drug that's going to make the vessels dilate? What? So let's say the vessels are tight and we're going to make them dilate. Why do we do that? So when they're really tight, the blood pressure can be really high. When we dilate them out, make them bigger, it drops the blood pressure. So one reason to give a vasodilator is when someone has high blood pressure. Are we good with that? The opposite is true, vasoconstriction. So what does anesthesia do to the vasculature? Anesthesia, propofol, narcotics, Dex, what does it all do? It causes vasodilation. When you guys go in the OR, you guys watch the blood, you guys get like, do people teach you a little bit about, what they're doing and what they're look at the blood pressure. you'll see a lot of times blood pressure tends to be on the lower side. As we've talked about, the anesthetic medications cause vasodilation. The anesthetic medications depress the heart, depress the inotropic state. So anesthesia in general tends to lower blood pressure. When the blood pressure is too low, what can I give? A medication that causes vasoconstriction. So here, my blood pressure is really low. I'm going to increase the pressure by causing the arteries to constrict. Does that make sense? Questions on that? Are we good or are we overwhelmed? Because I can't tell. Yes, please.
What do you give to make the muscles constrict again?
So we're talking about vasculature. We're talking about muscle. We're talking about most of your vascular resistance comes from arteries. So we talked about with MH, we talked about skeletal muscle. With the heart, we talked about cardiac muscle. With the vasculature, we're talking about smooth muscle. Okay. So then say your question again.
What can you give to cause vasculature to close?
Okay, so let's say it correctly. Vasculature to close, what is this? What would you call it?
More constrict, I guess.
Vasoconstriction. What do you call this? Vaso
Dilation.
dilation. Let's say it again. What is this? Vasodilation. What is vasodilation going to do to the blood pressure? It's going to bring it down. Think about this. Take a hose, a garden hose, and turn the water on. You have a garden hose that's this big and you turn the water on. And there's water coming out of the hose, right? Don't turn the faucet. Now conceptually think of, so the amount of water coming out of the hose is constant. And we have X amount of water coming out of this hose. If we leave the amount coming out the same, we don't change the faucet, what would happen all of a sudden if I made the hose this big?
It's gonna lower.
It's going to lower what is coming out of the hose. Now, let's say I got a hose and now the hose is like this big. What's going to happen?
It's gonna come out higher.
It's going to come out much, much faster. In addition, as it is really narrowed, what is the pressure in the hose? It's higher. And when I make it really big, what is the pressure in the hose? It's much less. How is that analogy? Help? Did I answer your question? Ask it one more time. No, it's okay. It's okay.
What is the drug that you use to?
Drug. We're gonna get to. We're gonna get to them. There are a number of different drugs we can give to cause vasodilation, and there are a number of different drugs we can give to cause vasoconstriction. Okay. So we're just going over terms. Do you guys understand the concept? Because we're going to start talking about drugs, and I'm going to say vasoconstriction, vasodilation. If you don't understand the terms, you don't know what the drug is doing. So are we good? Bradycardia and tachycardia. You guys are going to take ACLS soon, right? All right. So what does bradycardia and tachycardia mean? What's the definitions?
Brady is a abnormal low heart rate.
Right.
Tachy is a abnormal high heart rate.
Good. So how about a heart rate of 61? Is that bradycardia? Or is a heart rate of 59 bradycardia?
Too hard to tell. It's right in the middle. It's on the lower end.
There's a definition. There's a definition. Bradycardia is associated with a heart rate that is less than
60.
60. That's right. Now, you also, I'm going to go into something else. You also can abnormal. Take someone who is a marathon runner. Their normal heart rate at rest is going to be 40. Because their heart is so well trained. Is that abnormal? Take a guy who has severe coronary artery disease and has cardiac conduction problems, and his heart rate goes to 40. Is that abnormal? You bet it is. Okay, so low heart rate doesn't always mean abnormal. Okay, so if if bradycardia is a heart rate of less than 60, what is tachycardia? What's the definition? A rapid heart rate of greater than 100. And that heart rate, depending on depending on the EKG, may be completely normal. If you ran back and forth, you'll be in a normal sinus rhythm, but your heart rate will be increased. That's normal. Your body's compensating. Are there dysrhythmias associated with a high heart rate? You bet. You're going to learn all about them in the future. Okay. But today, we're just doing normal. We're not doing abnormal rhythms or anything like that. Are we good? Okay. Let's talk a little bit about cardiac and vasoactive drugs. What do you think vasoactive drugs are going to do? They're going to do two things. What do you think they're going to do? Vasoactive.
Gonna affect your blood vessels,
That's right. In what way? Two ways.
either increase or decrease.
Okay, be specific. Sound like a physiologist.
Blood pressure.
It's either going to cause vasodilation or vasoconstriction. There we are. Good. I knew you were right on it. I just wanted the terms. Good. All right. All right. So a drug, how does a drug work? A drug works on a receptor. So it's not the drug that does it. It's the drug that interacts with the receptor that causes a physiologic change. So there's some receptors that you need to know. And you guys have probably learned this in physiology already. It should be just review-ish. Okay, in the heart, there are beta-1 receptors. Beta-1 receptors. So have you guys ever heard of a beta blocker? If I gave a beta blocker and the heart is stimulated by a beta-1 receptor, but I gave a beta blocker, what do you think a beta blocker is going to do to the heart? Decreases heart rate. So let's look here. Stimulation. Stimulation is also called agonism. So stimulation of a beta-1 receptor is going to do what to the heart rate? Stimulation is going to do what to the heart rate? If I ran back and forth, my brain is going to secrete catecholamines. That's going to be an agonist or stimulus, don't write all this down, at a beta-1 receptor. When I'm exercising, what is my heart rate going to do? It's going to increase. So beta-1 agonism or stimulation is going to cause an increase in heart rate. I gave this example of isoprel, and I really don't want to anymore. I really want to give this example. Can anyone finish this for me? That's right. Epinephrine. Your body creates it and secretes it all the time. So epinephrine, you can give IV also, is an example of an agonist or a stimulant. It's going to do what to the heart rate? Increase the heart rate. That's right. If we can give a drug that is a stimulant on a beta-1 receptor, a stimulant at a beta-1 receptor or an agonist, we can do the opposite, as we just talked about. We can give a beta blocker, not stimulate the beta-1 receptor, but inhibit it. As we do, what is going to happen to the heart rate? Decrease. That's exactly right. Good. Examples, esmolol and labetalol. Now, what is your clinical application with all of this? Maybe I should have started there. In the past, we never used to have the complex Pyxis that we have now. These days, pharmacy stocks the entire Pyxis, right? And anesthesia people have access to that. In the past, guess who used to stock the anesthesia cart? You. That's exactly right. Do you guys still stock carts in the middle of the day? Okay, you guys still do, right? point. You're touching all of these vials. And if you're touching a vial, you should know what the drug does, right? Secondly, in an emergency, if someone says to you, get me labetalol, you know that labetalol is a beta blocker or esmolol is a beta blocker. You don't need to know the dose. You don't need to know more than anything about getting them the right drug and knowing that the drug is going to bring the heart rate down. Make sense? Lastly, let's say at your place, you're not stocking any drugs. Isn't there an anesthesia workroom? Aren't there a whole bunch of drugs in the anesthesia workroom? If you're grabbing a drug, you should know what it does. Okay. So examples of beta blockers. Has anyone seen the esmolol amp or labetalol amp? These are the most two common beta blockers that we give intraoperatively. Okay. I want you guys as a class, because I'm seeing some, I don't really know what he's talking about. And that bothers me a little bit. So it's a lot of stuff and it's all new stuff. So I want someone else to start. Someone start at beta 1. And as a class, you guys do beta 1 inhibition and stimulation. Someone start. I'll be your wingman. I'm not going to let anybody hit the ground. Go.
Like fill it in.
Do a discussion that we just did. Discussion on beta 1 receptors. Where are they? What does it do when it's stimulated? What does it do when it's blocked? Go.
So beta,
And this is not just for him. This is because he's not the only student in here. So you can start, but other people need to speak. Go.
beta receptors are found in the heart.
Beta 1 receptors. Beta 1 receptors are specific to the heart. Check. Another piece of information. Someone give me something else.
They're stimulated, it increases the heart rate.
When beta 1 receptors are stimulated, also call that agonism or stimulation, heart rate increases. Perfect. Can you give me an example of a drug that would cause that? Epinephrine would. That's exactly right. Acetylcholine. Perfect. Someone talk about inhibition. Someone new. You guys want to go home by 1? I do.
Lower the heart rate?
So talk me through it. It does lower the heart rate. Beta blocker. Beta blocker. So a beta blocker for the heart is going to work on what type of receptors?
You know what?
Beta 1 receptors, right?
Yes.
So we're either stimulating them to make the heart rate go up or blocking them to make the heart rate go down. So good. Can you give me an example of a beta blocker that we may use in the operating room?
Esmolol.
Esmolol or labetalol are 2 beta blockers. You know how you know what a beta blocker is? If a drug ends in olol, it's a beta blocker. Okay? There's metoprolol. There's a whole bunch of olols. Okay? Are we good with beta 1 receptors? They are located in the when we stimulate them, also called agonism, that is going to cause a drug that we can give to increase heart rate as a beta 1 agonist is called. We also can depress the heart. We would give a beta 1 blocker. As a result, heart rate would. An example of a beta blocker too. Esmolol or betalol. Are we good? I think we're good now. All right. Let's get off the heart. Let's go to the vasculature. Vasculature has to do with vasodilation and vasoconstriction. Drug works on a receptor. We talked about this. When we talk about the vasculature, we are talking about alpha receptors, specifically an alpha 1 receptor. Okay. So just like we did in the heart, different receptor, different drugs. Stimulation of an alpha receptor is going to cause what? Stimulation is going to cause what? Vasoconstriction. That's perfect. An example of a drug. Has anyone seen phenylephrine yet? Okay, good. You've seen phenylephrine in the OR. That's a vasoconstrictor. How about epinephrine? Would that cause vasoconstriction? It indeed does. It will have a cardiac effect, but it also has an effect on the vasculature. How about ephedrine? Has anyone seen ephedrine yet in the operating room? You have. That's going to cause vasoconstriction. So all three of those drugs are alpha-1 agonists. They all cause vasoconstriction. Last question. Why would you give one of those drugs? Why do you want to cause vasoconstriction?
The blood pressure's low.
The blood pressure's low. Good for you. So the blood pressure's low. The patient's dilated out because they're bleeding. They're dilated out because they're volume depleted. They're dilated out because you're giving them a lot of anesthesia. Their blood pressure's low. Do this. Give a drug like epi or the ones we just talked about, phenylephrine, ephedrine, vasoconstriction, bring the pressure up. Perfect. See, you got it.
I'm awake today.
Did he end?
I'm awake today.
You're awake today. It's good. All right. Inhibition. What do you think? And I don't care that you know that you can just forget this example. There's not a lot of drugs that we give that cause inhibition of alpha-1 receptors. There are some. I don't really care that you know. But what I want you to know is we can give drugs to cause inhibition or blockade of alpha-1 receptors. Where are alpha-1 receptors again? In the heart, right? Nope. Vasculature. Mostly arteries, also on veins, but most of your vascular resistance, your blood pressure comes from your arteries. Okay. So if I were to give a blocker, an alpha-1 blocker, what is that going to, if stimulation is going to cause vasoconstriction, blockade or antagonism is going to cause? No, right. Why would you give a drug that is going to cause vasodilation? Because the pressure's high and you want to bring it down. Good. All right. Here are beta blockers. Here's an example of esmol. Here's an example of labetalol. Beta blockers are administered and they have an administered to. They're administered to a whole lot. That's just stupid. Let me just change it. They're administered. And inhibit what receptors? Beta blockers inhibit what receptors? Beta-1. Where are those located? In the heart. All right. And here are two examples. I put these up here for a reason. Can anybody tell me what the reason is? Because you're going to be grabbing drug vials. You're going to be looking at drug vials. They're the same drug. But if I don't pay attention, I could make an enormous mistake. So if we look at esmolol here and here, it is the same drug. However, it is the same concentration. But I will tell you this, if you're used to grabbing this one for 10 years, which is blue top, purple label, and then you see this, you don't know. Pfizer changes drugs. You know why? Because drug manufacturers sometimes all of a sudden have production problems with a drug. If Pfizer needs a drug, they're going to buy it from another pharmaceutical company. And the packaging, that's terrifying, right? My point, read everything. I tell my students that. The best way to make a drug error is to not pay attention. Okay? Now, if you didn't know the okay, so you guys are going to be given this drug, right? let's say you give this drug over and over and over again. You hand people the vial. But today they ask you for another vial. You go to get it out of the workroom. And this is not there. This is there. Are you going to remember that it's 100 milligrams per 10 cc? You're not. But what you should do is go to the person you're handing it to and say, this is different. And then they can take a look to see if it's different in terms of the concentration. Look at this. Look at this. Is that dramatically different? This is twice as potent as this. So if I want to give 5 milligrams of this, I'm going to give 1 cc, right? Or actually, you know what? It is the same concentration. It's the same concentration. I'm sorry. You know why? The volume is twice as great here. So the volume is twice as great. The concentration is the same. You always know what the concentration is. It has to be put on a drug label. It's mandated in the United States. My point in showing you these is if you have any question, hand it to the anesthesia person and tell them, this looks different to me. Let them evaluate it. By doing that, you may absolutely positively prevent a drug error. Okay? Good? All right. Read everything. All right, look at these drugs. Nitroglycerin and nitroprusside. Same milligram dose, right? Are they different drugs? Nitroglycerin and nitroprusside? Do you see how easy it would be to confuse those names? They both start with nitro. What I want you to realize is the names are different. And if you're not sure and someone asks you, make sure you bring it to them and say to them, I'm not sure. I would rather you say, I'm not sure, as compared to hand me something that I asked for, I don't check it, and then I make a mistake. Okay? Are we good? That's it. We talked about 2 types of drugs. We talked about drugs that interact with a beta-1 receptor. We talked about drugs that act on an alpha-1 receptor. Drugs that act on a beta-1 receptor, beta-1 receptors are in the when we stimulate them, agonists of the beta-1 receptor, we do what to heart rate. When we give a beta blocker and inhibit beta-1 receptors, we do what to heart rate. Drugs work also on the vasculature, primarily alpha-1 receptors, which are primarily located on arteries. When we give a drug that is an alpha-1 agonist or stimulant, what does it do? It causes vasoconstriction. Why do we give a drug that causes vasoconstriction? Because the patient's blood pressure is low. We can also give a drug that has an inhibitory effect on alpha-1 receptors. As it does, what is it going to cause? Vasodilation. Why would we give a drug that is going to cause vasodilation? The patient's blood pressure is high. That's it. You got it. All right? Yes, please.
What are beta blockers administered to?
Say it again.
What are beta blockers administered to?
So they can be administered to a whole bunch of different things. So if someone's heart rate is really high, if they have a dysrhythmia, beta blockers chronically are used for people with coronary disease. They slow the heart rate down. By slowing the heart rate down, you decrease the amount of oxygen that the heart needs. So there are a whole lot of reasons that patients get beta blockers. In the operating room, we give it IV. The primary reason is to bring the heart rate down. Does that answer your question? Yes, sir.
To add on to that,
Yeah,
you can correct me if I'm wrong.
no, love it.
For cardiac radicals, one of the main reasons they apply vasodilators is to obviously reduce the heart rate, well, blood pressure and heart rate. but it's also to help with getting them on the bypass machine. So if the arterial blood pressure is too high and they start doing the incisions on the vessels, then there'll be too much blood pressure, and then you'll have like a lot of like blood loss. So they want to prevent that. And then once they get them on the bypass, then I'm not really sure what they do, but they contain.
Yeah, so in the future, one of my next lectures for you is not only going to be looking at heart rate, but is also going to look at other factors that affect the heart, such as preload and afterload. We've already talked about contractility. When you give a beta blocker, and we'll talk about this next time, so don't worry about this. When you give a beta blocker, it's important to know that it decreases the heart rate. But it's also, if you're giving it, really important to know that it decreases contractility also. And so you say to yourself, you don't need to know any of this. You say to yourself, why is that important? If you're giving an anesthetic, which depresses the heart, and then you're going to give another drug on top of it, which depresses the heart directly, you better be sure that someone has adequate cardiac function before you give that drug. Because if you depress the heart too much, you're going to have to decrease the anesthetic that you're giving, or have such low blood pressure that the patient's at risk for a stroke, having a stroke, or having a heart attack. Okay, that's more complicated. We're not going to talk about that because you're not going to be giving these drugs correctly. But in the future, we're going to talk about those factors. There's more to learn. There's always more to learn. Okay. Other questions, but I don't want you, that's good thinking. I love it. And you guys will understand more as you see other surgeries and apply the information. I don't want you to know all about what I just said. I don't want you to know all about what he just said. I just want you to know what we went over. Are we good? All right, next drug class. So we're going to get away from cardiac drugs and vasoactive drugs. Why do we give gastric prophylaxis? You guys see this in pre-op? Why do you has anybody held cricoid pressure? Why do you hold cricoid pressure?
Red stuff.
Say it again, dear. What did you say?
Probably because they couldn't see.
Okay, so you did something called, you actually were pushing on the larynx to improve their view. That you can do, because the cords are housed right there. Why did other people apply pressure directly to the cricoid cartilage? Okay, he said prevent aspiration. What did you guys say back there?
I was gonna say something.
Prevent aspiration. You would be exactly correct. What does aspiration mean? Yeah. So stuff coming up out of the stomach, and if someone's unconscious, so you're conscious, right? If you ate a lot of food, and then you kind of barf some up, what would you do? You'd cough violently, right? As it got around your pores. Someone's anesthetized, they're not going to cough. That stuff is just going to go into their lungs. And if puke goes into your lungs, so you guys erped every now and again, right? You erp a little bit. It burns, doesn't it? Imagine a significant amount of that going into the lungs. Imagine what that's going to do to lung tissue. It's going to burn it, and it's going to destroy it. So that's why we do a rapid sequence induction. We are concerned that someone is at significant risk for gastric aspiration. Has Tony or Sarah talked to you about groups that are at high risk for gastric aspiration? So I see some yeses, and then I see some nos. So let's hear, what did you guys learn? Who is at risk for gastric aspiration?
Patients.
So you did learn it. Good. Emergency patients. Good. All right, good. What else? Obese patients.
Patient.
GERD. Trauma. Diabetes. Hiatal hernia. Neonate. Yeah. So all those groups are at high risk. We're going to do a rapid sequence induction, but a rapid sequence induction and cricoid pressure is not perfect. People can still aspirate. If they do, wouldn't we want them aspirating something that's less acidic? The more acid and the greater the volume, the more damage is going to be to my lungs. Make sense? So look, we'll go over NPO guidelines in a second. There are drugs that we can give, here they are, in terms of decreasing the incidence, decreasing the volume, and also decreasing the pH. So let's go over this. So volume, do you understand what that means? So volume is amount, right? Second, gastric pH. The lower the pH, the more acidic it is. The more acidic it is, the worse it's gonna burn the lung. That makes sense. Very potent acid, very as compared to water. Which would you rather aspirate? Very strong acid or water? Me too. Okay. These are the drugs that we give. Metoclopramide, famotidine, Bicitra. I don't want you to memorize, I don't even want you to really look at this. These are the drug doses. You can have it there for whatever reason if you want. But these are the 3 drugs we're going to give, and they work differently to achieve what I just said. And we're going to go over that on the bottom. Okay? Are we good with the 3 drugs? Metoclopramide, famotidine, and Bicitra. We're going to talk about this table in a second. Before we talk about this table, I know Tony or Sarah or someone has talked to you about NPO guidelines. I know that's happened. Why do we have NPO guidelines? Yeah. So if an hour before my surgery, I ate like a half a pizza, that's not good. You know why? Because that pizza's still in my stomach an hour later. And as I go to sleep and all my stomach and all the sphincters in my esophagus relax, that pizza or pizza juice comes up and ends up in my lungs. That's why we have people we have them NPO. Okay. Do you know the guidelines? You're going to need to know this for your tests and for your boards. These are the guidelines. So clear liquids, we can have up to 2 hours. There's a difference between breast milk and infant formula. It has to do with the type of protein. The type of protein in breast milk is digested more rapidly, which is why the guidelines are only 4 hours. So mom could feed the kid and the kid could have surgery 4 hours later. However, if mom wasn't breastfeeding, but was using non-human, so mom's using commercially available formula, different protein, doesn't move through the GI system as fast, meaning that the guidelines are longer. So mom can feed the kid with non-infant formula, but the kid has to wait for 6 hours because we want to make sure that there's no residual formula in the kid's stomach. And then lastly, meal. So the old guidelines were 8 hours. Some people will say 6 hours. And this is a light meal. You know why that's not good? Because some people think a light meal is a pizza and a hamburger and fries. And a milkshake. Why not throw a milkshake in there? Would it be a strawberry one, a vanilla one, a chocolate one, or all 3? That's the Neapolitan one. She's doing all 3 at the same time, right? You know, this may mean like a piece of toast and, you know, maybe an egg or something like that, but it's not specific. Do you know these guidelines? You should for tests and for boards and for clinical. Last part on this. These are the 3 drugs I just mentioned up above: famotidine, Bicitra, and metoclopramide. You may need to write some stuff down here. Okay. Famotidine does what? Famotidine is Pepsid. You guys hear Pepsid on TV, or you can get it over the counter. What does Pepsid do? It is an H2 blocker. It blocks histamine receptors in the gut, in the stomach. It decreases acidity. If someone has really bad acid, Pepsid is a drug that'll work. You can get it over the counter. So what is Pepsid or promote? You could write Pepsid. I should just write Pepsid. Pepsid. The onset is 1 to 3 hours. So if I give it IV, it doesn't start working for 1 to 3 hours. It's going to do nothing for me right now. So what's the clinical correlation? If I have a patient who is at risk for gastric aspiration, and I know they're coming in the OR, I have to order the drug at least an hour ahead of time and they get it. Because at the time they come into the OR, if I gave the drug 5 minutes ago, it does nothing. Does that make sense? Okay. Famotidine or H2 blockers are really good at decreasing acidity. So put 3 arrows down. That's its claim to fame. It decreases the acid. What does it do to volume? The amount? 1 arrow down. So it actually does decrease volume, but not a ton. So primarily, famotidine decreases acidity. Next, Vicitra. It's taken orally. We don't give this drug that often. It makes people puke. It's kind of nasty. It tastes like a really sweet tart. It's taken orally. It's an antacid. Look at the onset. Look at the onset. 5 to 10 minutes. Why? I'm drinking it and it's going right into my stomach. It's having an immediate effect. So the onset is fast, which is desirable, right? What does it do to acidity? Put 3 arrows down. That's good. Decreasing acidity is good, right? What does it do to gastric volume? The amount of my stomach. I just drank 30 cc's of this stuff. It increases it, and that's not what I want to do. So we can decrease acidity quickly, but we're going to give up a little bit of what we want. We're going to increase volume. Is that volume increase? Is that what causes the nausea? It has a really strong taste. It's not the volume, it's the taste that makes some people puke. So you guys know that the candy tarts? You know that? So I've actually tasted Vicitra because I'm like, I want to taste what it tastes like. Don't tell anybody I did that. But like if you took the entire roll of sweet tarts, opened it up, and stuck it in your mouth at one time, that's what it tastes like to me. It's a really strong taste. Okay. The last drug, metoclopramide. Metoclopramide is called, you don't really need to write this down, a gastrokinetic, meaning it moves volume through the GI system. In terms of acidity, Vicitra does 0. It does, I'm sorry, I'm on metoclopramide. Metoclopramide does 0 to acidity. It doesn't touch it. But what does it do to gastric volume? Put 3 arrows down. So it really is good at removing residual stuff in the stomach and pushing it into the intestines. Once in the intestines, you can't ask for it. Okay? So let's summarize. Look, so if our goal is to decrease gastric volume and to increase acidity, famotidine, really good at decreasing acidity and kind of okay at volume. The bad part is it's going to take an hour just to start working. We have Vicitra, the antacid. That's going to decrease acidity now. However, it's going to do the negative of slightly increasing volume. Last, we have metoclopramide that does nothing to acidity. We have these other two drugs to work on acidity. What does it do to volume? It really decreases it. So by giving the three drugs in combination, we achieve what we want, decreasing gastric volume and increasing gastric acidity. So if someone does vomit, the damage to their lungs, fluid that goes into it, doesn't damage it to any degree. Yes, sir.
Can you combine them?
Combine them how?
Like,
So this is taken orally. This is the oral fluid, so no. And famotidine is given IV. It's given in a piggyback, so it's given as a IV infusion in a really small bag, and it goes in over about 20 minutes. And metoclopramide can be given. You don't want to push it rapidly. You want to give it slowly. All of these drugs, just so you know, especially related by Citra, have side effects. So don't write any of this down. If I give famotidine really fast, I can have someone that develops a bronchospasm. If I give metoclopramide really fast, it's a gastrokinetic. It moves stuff to the GI system. The way it does that is by increasing acetylcholine. If I do that and give that drug really rapidly, people can have uncontrolled body tremors while they're awake. So every drug has a side effect associated with it. How is that? You didn't write any of that down. That's fine. So the answer is no, the drug should be given, they should be given independently. Are we clear?
Give like famotidine like pre-surgery and then like right before give like.
What most often happens is someone with high risk for gastric aspiration, famotidine and metoclopramide will be ordered in pre-op.
So you can give them like with each other.
Yes, you give them with each other.
Is that your question?
I thought you meant mixed.
oh yeah, but the way I said it now, which how she articulated, I was like, yeah, no.
Yes, you can give all three of these drugs at the same time. You can't, if you're talking about IV drug and IV drug, you can't mix those two IV drugs and give them in the same syringe or something like that. I'm sorry, I thought that's what you meant, but yes, they can be given at the same time. Okay, thank you. Thank you for making me clarify that. Are we good? We've only got a couple more drugs to do. And I've only got a little bit more time, so why would we give an antihistamine? Allergic reaction, that's exactly right. So if someone has an allergic reaction, an antihistamine is given. How does an antihistamine work? What do you think it has? What do you think the effect is? To block histamine. That's why it's called an antihistamine. So in an allergic reaction, something goes into the body, triggers a mast cell to open up and dump tremendous amount of histamine chemical. When histamines interact with histamine receptors on tissue, people can develop rashes. They can develop bronchospasm and trouble breathing. In the worst case scenario, they can have little to no blood pressure. And you've also heard of people dying from an allergy, peanut allergy or something like that. So this is no joke. What is an antihistamine going to do? Is if histamine is going to interact with these receptors to cause the effect, give an antihistamine. You're going to do nothing to the concentration of histamine, but you are going to block the effects at the receptor level. And therefore, the allergic reaction doesn't happen. So for the most part, antihistamines are given in the operating room if someone has an allergic reaction. Which one do we give? Which one is the most well-known that we give IV? It's written right here for you. A big name, diphenhydramine, little name, more common, Benadryl. And why do we give Benadryl in the OR?
Antihistamine.
What? An allergic reaction, that's right, good. Talk to me about signs. Let's say you're walking by a patient pre-op. And all of a sudden you see there's something not right going on with the patient. Could be 100 different things, right? Can you tell me some signs and symptoms associated with an allergic reaction? Rash. Okay, rash. Does everybody who develops an allergic anaphylaxis, a big name for that is anaphylaxis. Does everybody develop a rash? No. Okay, but check. What else? Say it again. Clammy skin. Yeah, sure. It's a shock state. That's possible. A lot of other reasons that people can develop clammy skin. What else?
Inflammation.
Inflammation. Be specific. Because I walk by a patient's room and I see them being anxious, and I don't think inflammation. You're right, though. Histamine release will cause inflammation. How about the lungs? You guys know, I won't ask you if anybody has really bad allergies. Have you guys heard of an EpiPen? I know you guys have. Why do people who have a peanut allergy carry around an EpiPen?
Because in the event of an attack, the Broncos.
That's right. So possibly respiratory issues associated with allergic reaction, such as bronchospasm. They can't breathe, right? Okay, check. So let's say I walk by a patient's room. They're cold and clammy. They're very anxious. They're having trouble breathing. What else? What else about a histamine release? How about, what do you think their blood pressure is going to be? Very significant histamine release. Isn't anaphylaxis a shock state? In shock, what is the blood pressure? High or low? Low. That's right. Histamine. So last part. I know I'm almost out of time. Histamine causes vasodilation, massive vasodilation. What is vasodilation going to do to your blood pressure? Drop it. That's right. Good. All right. I've heard a number of people say bronchoconstriction or bronchospasm. If that happens, we have a drug to help with that. Has anyone grabbed albuterol? Yeah. I see some yeses. Good. Albuterol comes as a mist via inhalation, and there it is. Albuterol, reason for use. What's the reason for use? Bronchospasm. Who's more likely to have a bronchospasm? Good, you know that. So albuterol can actually be given in pre-op to patients and then taken into the operating room and given more albuterol when they go to sleep. Albuterol is for bronchospasm. Good. Administration is an IV. Inhalation, I love it. Perfect. All right. Has anybody heard of the term, the drug Toradol? Okay. Toradol is a drug that can be used. You can write down, it's like IV Advil. IV Advil. It's a non-steroidal anti-inflammatory drug. An NSAID. Isn't that what Advil is? Yes. Advil is an NSAID. Let's not worry about the mechanism of action. It is wonderful for postoperative pain. Do you guys ever get to walk around the post-op area? You guys ever get to do that? You should. Walk through the post-op area. You're going to see patients very comfortable and not in pain. You would see some patients that are in an incredible amount of pain. Okay? We treat pain. That's our job. How do you treat pain? Most often with a narcotic. But we talked about narcotics. What's the negative of giving a narcotic? Makes people sleepy, causes respiratory depression, increases the time that they're in post-op. If you take Advil or a drug like Advil, does it cause respiratory depression? Advil. Does it cause you to be sleepy? Does it have any effect on your level of consciousness? Does Advil work well for pain? You bet it does. So Toradol is one of those drugs that we can give an advantage. I just mentioned them. Doesn't make people sleepy, doesn't make them have vomiting, doesn't cause itching, doesn't cause respiratory arrest, and we can use it to help decrease postoperative pain. Okay, so indication, we're going to scratch out mechanism of action, and indication, pain. Good, 2 more drug classes. I got it. 6 minutes. I know. Decadron. Have you heard of Decadron? Has anyone stocked Decadron? I see some yeses. Good. Decadron is given with almost every anesthetic. It's given at the beginning in pre-op. Why would we give Decadron? And Decadron, just so you know, is a steroid. Why would we give that? Anybody? Let me give you a hint. It's anti-nausea and vomiting medication, right? So steroids have an anti-nausea and vomiting effect.
Is that anxiolytic or antiemetic?
It's antiemetic. It's antiemetic. Steroid will do nothing as an anxiolytic. Anxiolytic, the most perfect example is Versed or a benzodiazepine. Yeah, you can give a steroid to someone and they'll have no depression in their brain at all. All right, so let's not worry about the mechanism of action. I'll go over this with you right here. Indications. What is the indication? Postoperative nausea and vomiting. Now, what is the incidence of postoperative nausea and vomiting in the general population having anesthesia? High. So many times we're going to give this prophylactically. What does prophylactically mean? Preventatively. That's right. So someone's not even going to have nausea and vomiting. We want to prevent it to happen. So many times Decadron will be given in the preoperative area. Okay. Decadron for postoperative nausea and vomiting. Yes, sir.
I'm not sure what's the mechanism of action for Decadron.
Yeah, let's do that right now. You can write down mechanism of action having an anti-prostaglandin effect. You never need to know that, and you never need to say that to anybody, and you'll never have to answer that on a test. Look at this picture here, because you're going to see patients in PAC. Has anyone had anesthesia and had nausea vomiting? I have. It's horrible. If you get the stomach flu and you're nauseated and vomiting, you puke and then you feel better until you have to puke again, right? With the stomach flu. You have anesthesia, you have nausea, vomiting, you puke, and then 2 seconds later, you feel as bad as when you puked the first time. It is horrible. It is absolutely positively horrible. Okay. Why do people puke? This is conceptual, no testing stuff. There's something called a vomiting center in the brain. It's located in the medulla. And what this area is, it's called the CTZ, chemoreceptor trigger zone. It modulates nausea and vomiting. Nausea, vomiting is protective, right? If I eat some nasty food, I throw up. Why do I throw up? It's my body's way of getting rid of the nasty food, right? And not having any more of it in my stomach. Lots of things stimulate this area. I'm gonna go here. And I'll just go here for a second. Emotional, right? Has anyone seen anybody so unbelievably emotionally distraught that they throw up? So there's that input to the CTZ. For us in anesthesia, we're here under treatment related. So look at all the medications and their bigger list. All these medications sensitize this area in the brain to nausea and vomiting. So that's why the incidence is high. In a typical general anesthetic, how many drugs are we giving you guys? 10, 12, 14 different medications. Some people don't have the predisposition, but many people do. They estimate that the incidence of postoperative nausea and vomiting is about 70% without treatment. So that's why we give Decadron unless there's a reason not to, because the incidence of postoperative nausea and vomiting is high. How is that, sir? Is that good? You good on that? Any questions on that? Okay. These are examples, so I don't want you to memorize this at all. It's here for you. In the CTZ, they're not only prostaglandin receptors, but they're all these different kinds of receptors. The more different receptor types we block, the less possibility of postoperative nausea and vomiting. So I can give steroids, Decadron, that are going to inhibit this receptor. But another drug that we give constantly during an anesthetic is Zofran. Zofran works on serotonin receptors and on and on and on. So I don't want you to memorize this, but someone may say to you, can you give me some Zofran? Someone may say to you, can you get me some Decadron? And I want you to know that these drugs do work on the CTZ. Okay, so don't memorize that, not on a test. Are we good? I've got it's 12:31, but this is easy. I don't know a lot about antibiotics, to be completely honest. When they order them, I give them. However, I do know one thing. What is the most important thing? From our perspective, it's written right here, and you should know that. From our anesthesia perspective, about antibiotics. What are we always concerned about? An allergic reaction. So antibiotics are a class of drugs that people can have allergies to. So that's what I'm always on the lookout for. Surgeons order antibiotics. I don't want you to memorize this because I don't even know this either. And every year I look at this picture and go, it's kind of cool. Different antibiotics, they're different classes, right? Penicillins, cephalosporins, erythromycins, blah, blah, blah. Man has figured out how to kill bacteria in different ways. So for instance, these antibiotics kill this protein that killed this bacteria. These antibiotics kill the cell, the wall, the membrane wall of the bacteria. These antibiotics, blah, blah, blah. So different antibiotics kill bacteria in different ways. Okay. In anesthesia, we give broad spectrum antibiotic, most commonly NSAID. You guys have heard of NSAID? Okay, we give that intraoperatively. It's called broad spectrum. What does that mean? Broad spectrum. That it kills good. It kills a wide variety of bugs. People are at risk for developing infection postoperatively. So just as we talked about giving Decadron prophylactically, because someone doesn't have nausea and vomiting, we don't want to get it. Antibiotics are given prophylactically most often. They don't have an infection, but we don't want them to get one. Does that make sense? Good. So I'm not asking you to memorize drug classes. They're all these drug classes. I'm not asking you to memorize mechanism of action because I don't remember that. But I do want you to remember class antibiotics are associated with what? An allergic reaction. Excellent. Sure. Give me 1 second. This will be fun. You'll like this.